Yeah, let's go ahead and do that. All right. All right. Thank you all for joining today. There seems to be a lot of activity on campus around dementia and Alzheimer's, and we're excited today to be on that trend in today's Fall 2025 series seminar. We're excited to welcome Dr. Jung Kwak, Associate Professor and Interim Director, Luci Baines Johnson, and Ian J. Turpin Center for Gerontological Nursing at the UT Austin School of Nursing. Dr. Quack's research focuses on implementing and evaluating psychosocial interventions that support caregiving, improving care transitions, and enhancing the well-being of people living with dementia and their care partners. Her current research includes studying palliative care and outcomes among culturally diverse hospitalized dementia patients and their family caregivers, investigating the impact of training community health workers to provide care transition support for these patients and families, and examining the effects of innovative curricula on the knowledge, skills, and competencies of health profession students focused on best practices for Alzheimer's and dementia care. Her research has been featured in various news and media outlets, including the Associated Press, USA Today, and Consider the Conversation, a documentary film about end of life care. Please welcome Dr. Quack.
Thank you, Jay, for the introduction. So I'm going to share the screen. Let's see. I want to make sure that you can see right. All right. So everybody can see the slide? Okay,
Yeah.
great. Um, so then I'll get started. So thank you, and good morning, everyone. Thank you for inviting me to share some of our work that we are doing at the School of Nursing. And today, particularly, I will share our work on the CDART, which is a community-based transitional care model, was the co-designed to support persons living with dementia and their caregivers during the vulnerable hospital to home period. Before I start, I'd like to acknowledge our collaborators as well as funders across different hospital systems, universities, as well as community organizations. And of course, we couldn't do this without participants that include the persons living with dementia and their family caregivers. So today I'd like to briefly share with you about why this work matters, specifically supporting persons living with dementia, their family caregivers during care transition, and describe our pilot intervention study. So first, dementia matters. In the United States, the number of people living with dementia is expected to double by 2060, reaching 14 million. And in Texas alone, we have almost 500,000 persons living with dementia and over 1 million unpaid family caregivers. And their financial as well as emotional and the systematic stress is enormous. And we simply just don't have the workforce or infrastructure yet to support this population adequately. And providing person-centered care doesn't happen in isolation. It really truly requires a team. And at the center of the team is family caregivers. So currently in the United States, there are over 60 million people who are caring for persons living with dementia. Most of them are women juggling caregiving responsibilities with their full-time jobs and parenting. And they're not just the helpers, but they are also essential care management and the self-management partners. They manage symptoms, coordinate care, and make important decisions on behalf of the persons living with dementia. And caregiver keeping also comes with a heavy emotional and physical burden. And many experience chronic stress, and their own health and well-being can suffer as a result. That's why supporting family caregiver is just not an add-on, but is actually a core part of improving dementia care. And one of the most challenging aspects of managing dementia and caregiving journey is managing care and transitions. Care transitions are what we call a perfect storm of patient safety. This is the period of a high risk of medical error, burden, and receiving treatments that are not reflective of their goals and values. This is also the time of disruption and care continuity and coordination. And the risk for hospitalization for persons living with dementia is almost double or the 2 times than their non-dementia peers. And they're also more likely to experience poor outcomes as a result of hospitalization. And these are the moments when families are left feeling incredibly overwhelmed. In fact, 2024 study by Alzheimer's Association found that 70% of the dementia caregivers feel stressed when coordinating care and navigating healthcare. And the majority of family caregivers will support having a care navigator to support them throughout their journey. So, given the significance of care transition, there are many models to support care transitions that have been developed. And models like the transitional care model and Project Red have improved outcomes in other general population. But still, poor outcomes still exist for the persons living with the dementia. And there have been models that have been adapted specifically for persons living with the dementia. But first, there are very few. And the second, these dementia specific models are resource intensive and complex and very hard to scale, which highlights a critical gap. And these limitations motivated our study. So we first wanted to really conduct our needs assessment study first to really identify the specific needs of persons living with dementia, their family caregivers during care and transition. So in our mixed method studies, we interviewed 36 families of hospitalized persons living with dementia. Many of them are from the Latino, African American backgrounds, so that we can understand their experience with inpatient palliative care. Inpatient palliative care is offered at over 80% of the US hospitals. It is known for their expertise in symptom management, goals of care conversations, communication, as well as caregiver support. So access to palliative care while hospitalized has the potential to improve the outcomes for the persons living with dementia. And in this study, we learned about their priorities, struggles, and what kind of support they really needed beyond symptom management. First, we found that patients across various dementia stages were actually referred to and received palliative care. This was somewhat surprising because in practice, many dementia patients do not receive palliative care until the very end stage of their illness. Second, not surprisingly, the most frequently reported challenges by caregivers were managing health issues, emotional stress, as well as the decision making. And we found different needs for support being emphasized at different dementia stages. For those in moderate stage, behavior management and safety at home was a major concern for caregivers. And for those at the more advanced dementia, long-term placement was another key concern. And for end stage, many caregivers were surprised that the families were at the very end stage and struggling to make end-of-life care decisions. And also, fragmented communication and unclear guidance was another important challenge that caregivers highlighted. And these are just a few of the statements that they shared with us that highlighted their experiences. And caregivers told us that they didn't know whom to turn to, and they described their experience as fragmented with having to work with too many teams, while there was unclear communication, even with the palliative care support. That's what led us to design something that could fill that gap, which is our CDAR intervention. And the CDAR stands for Connecting and Empowering Persons Living with Dementia and Caregivers During Transition. It is a hospital to community care transition model designed to support and deliver emotional support, dementia education, and navigation assistance throughout the transitions for these families. Importantly, this support is delivered by a trained community health worker or community health worker, we call it a CHW, who meets families where they are. And this was a collaborative effort with the hospital systems, community-based organizations to improve caregiver engagement, discharge planning, and post-discharge navigation. And so in spring and summer 2024, we worked closely with the hospital system and our other stakeholders to identify key challenges in inpatient, outpatient, community-based care. We also wanted to define the role and training needs of community health workers and to develop effective caregiver engagement strategies. And during this time, we also have refined our intervention based on partner recommendations. And we we implemented a feasibility study, and currently we are analyzing our data. And then this slide brings us to the heart of the CDART model, which is the community health worker. So community health workers are trusted frontline workers who share lived experiences with the communities they serve. And they are not clinicians, but they are vital. They offer emotional support, help families understand dementia, guide them through discharge, and connect them to local services and help them navigate the system. And we designed the role of the community health worker based on what both caregivers and healthcare system partners told us mattered the most. So caregivers wanted the education, culturally sensitive guidance, and essentially essential help in terms of navigating life after the discharge from the hospital. And health systems wanted to improve communication between the teams, reduce step burden, and also prevent readmissions of the patients. And the community health worker was the bridge that could do both. And this is what our intervention process looks like. And the community health worker makes the initial contact, builds a relationship, and follows the family across discharge into the home settings and offering ongoing navigation, education, and emotional support. Now, in terms of the study design, this was a single-site, single-arm pilot study. And our primary hospital site was Del City Medical Center. And our initial goal was to recruit 40 dyads. And our benchmarks for the feasibility and acceptability were recruitment rates, completion of sessions, meeting attendance, and caregiver satisfaction. So during our study period, we recruited 34 dyads who completed the baseline interviews. And most of the patients had the substantial ADL and the IADL support needs. And caregivers were mostly adult children or spouse, and many of them also reported significant health challenges and high levels of stress and burden. One of our feasibility benchmarks were retention rate, and our retention rate was 44%, while our goal was 70%. However, what was really striking was that mortality accounted for almost half of the attrition. This indicates to us that even though we targeted mild to moderate patients for our study recruitment, these patients were quite vulnerable and frail, and many received the support a little too late in their dementia disease trajectory. In terms of their support needs, we have identified different areas of caregiver support. So our community health worker has engaged in connecting them to various services in the community, engaged in advocacy, and also facilitating access to different social services in the community after patients are discharged from the hospital. In terms of acceptability, caregivers rated the support to be pretty high. In terms of our preliminary data on its potential efficacy on caregiver outcomes, we found significant improvement in terms of the caregiving coping scale, score. So actually, even though it looks like the red dot shows a decrease, actually the decreased score is actually better improved outcomes for their coping. And there was a significant improvement. And we also found a trend for improvement in terms of the caregiver burden. So our research confirmed that hospital to home transition was a critical period for patients with dementia and caregivers, which was often fragmented and stressful. And using community-based participative research principles, we could design our CDAR intervention with the hospital providers, community partners, and caregivers to identify unmet needs and reflect their priorities and experiences. And the community health worker served as a bridge between the hospital discharge and community supports. And their role included providing emotional support, dementia education, connecting families to services, follow-up care, supporting communication across systems. Caregiver rated community health worker support as highly acceptable, and we found that integrating community health workers as trusted, effective members of an interdisciplinary team was feasible. In sum, our CEDAR intervention demonstrated potential to improve the caregiver preparedness and also reduce stress, enhance patient safety, quality of life post-discharge, also strengthen continuity during the transitions. And our next steps include building training opportunities for community health workers. And currently, we are working to expand implementation as well as a study proposal to evaluate the long-term outcomes to inform the dementia care policy as well as workforce development. And that is it for from my presentation. And thank you again for inviting me to present our intervention. And I will stop here.
Thank you very much, Dr. Kwak. Are there any questions?
Yeah, I have one. Great presentation, by the way. Thank you very much. I like the work that you're doing. The 50% attrition based on caregiver, not caregiver, but death. You mentioned advanced stages of frailty. And so do you have an opinion now about the type of person that or patient that would benefit most from this? Should it be a little less frail, I guess, or earlier onset dementia? If that's, I don't know how to measure that. But anyway, just your thoughts about that.
Yeah, so one of the big lessons that we learned is that we really were really mindful of the fact that oftentimes patients were not diagnosed. So oftentimes that they're diagnosed late in the disease process. And even if they were diagnosed, maybe they are not going to be captured through the hospital admission data. And
Hmm.
so we really we spent significant time to really make sure that we could screen the people who are also suspected of dementia, right? And but still, despite all our efforts, what we found is that still the caregivers, more patients, more at the advanced levels were more likely to really be identified and then enrolled our studies. So we really do think that we have to be really proactive and really should target even at the mild stage or even people who are suspected it without even having the diagnosis because of those underdiagnosis, underdetection, but also the fact that oftentimes when they're diagnosed, they are much significantly later.
Yeah.
So yeah, and I think that that's when we can, I think community health worker can definitely be much more effective in terms of making sure to making sure that they are connected once they're discharged from the hospital, connected with the community resources and better prepare for the rest of the disease trajectory.
Yeah, and
Thank you
so
for the question.
that gets me into another question about cost. Does one have to have a diagnosis of dementia to be eligible for CHWs or other type of services that the medical system will pick up the tab versus an individual?
So that's a really, really important and good question. So in terms of care transition support, so I mean the NIH, for example, or DSHS has really invested a significant amount of funding to develop care transition support interventions. And oftentimes they are implemented in the acute care settings. But even though many models have been developed, they have not been really adopted because we don't really have real or Medicare, let's say, diagnosis code or the service code to really pay for that, right? So where the healthcare systems, they have a more integrated healthcare systems or value-based healthcare systems are much more likely to actually offer these types of programs because then, it's because value-based and they do know that having a care navigation actually, decreases substantial cost to the healthcare system.
Mhm.
However, a lot of other fee-for-service or others, still the majority of healthcare systems are not value-based. They are not necessarily really integrated across the different programs and the services. So they tend not to offer this kind of programs. So it's really up to each individual institution to offer it. Now, for the dementia patients, Medicare right now has a demonstration projects where the CMS has a demonstration projects where they are actually doing this dementia care navigation program. So that covers navigation. However, you need to have diagnosis.
Mm.
So it still leaves out a significant number of the patients who are not diagnosed, right? Who still have a dementia but haven't had a chance to get diagnosed. So it's kind of like a multi-pronged kind of like, I mean, I guess it's different various responses to your question. I
Yeah.
hope that sort of gives you some sense of where we are in terms of care transition support for dementia patients.
No, that's helpful. It sort of feeds into my interest in cognitive decline. And so how does one define? We could talk some other time, I suppose, but what I'm thinking is how do you define it? That's one thing to say, I think you have this, or you're showing signs and symptoms, and then reaching the criteria point for eligibility for, dementia treatment or other forms of cognitive decline treatment is an insurance question and an eligibility question. And so I want to try and figure that out, but don't have to answer that big question right now. But
Yeah,
thank you for your answer.
sure. Thank you for the question.
So, sorry, I have a question. What would be your recommendation to make community health workers available in those networks or the systems that aren't very integrated or they don't have or they're not value-based? I mean, would it be a partnership with community-based organizations to provide to work within hospitals to provide these workers? Or I mean, how is there, do you have a particular model that seemed to work or that you were you able to look into that?
Well, so in terms of the community health workers really supporting, providing the care transition support, especially from the hospital-based side, we don't have enough evidence, right? Like, so we need to build the evidence base to make sure that community health workers can be trained and they can deliver the support consistently. So there's that, like, that's one of the questions. And also we need to really, like, our team is preparing for the next efficacy trial application to really test more extensively in terms of the efficacy of this support. And then, and I think that's why, when we developed this project, we had a pretty good idea about how our intervention was going to work. We had our ideas, but we really wanted to work with our stakeholders, including healthcare systems, to see what their priorities are. And one of, obviously, they really do want to reduce readmission. That is one of their priorities. And then so our goal was to make sure how do we really strengthen the support the community hospital can provide so that we can prevent the readmission. So we are working with the efficacy trial proposal. And the second is that, also they care about how it would actually reduce burden on the staff and increase the satisfaction among the staff as well as satisfaction among the family caregivers. And those are actually important incentives for hospital-based hospitals and other healthcare systems. So we are trying to really target the outcomes that are important to those stakeholders so that we can also show the efficacy and effectiveness. And I think there is also increasing interest in terms of community health workers playing more important role in the healthcare system. And so I think in the primary outpatient settings, community health workers can be actually reimbursed as long as they're supervised. The question is then in the hospital settings, can community health workers also be reimbursed? That's a larger policy questions, but I think that there are other alternatives and the ideas that we can really think about how we can expand availability of community health workers within across various healthcare systems.
Thank you.
Any other questions for Dr. Kwak? Right. Well, thank you all for joining us today. Thank you so much, Dr. Quack, for taking time out of your busy schedule to present this important information to us.
Yes,
Kyle?
thank you. Oh yeah, I was just saying thank you so much. Yeah, we'll be posting video of this or recording of this session on our website hopefully today, hopefully this afternoon, and I will send that around to folks as well so you can share it with whoever you like. And then don't miss our next seminar won't be until it's November 13th. But I'll send some emails around with information about that as well. But thank you so much, everybody. Take
Bye-bye.
care.
Bye,
Bye.
everyone.